This is a small clip of our chairman, Sri Indravendra Amarlal Modi. Let me tell, sir, probably it is a record for medical fraternity that in such a mammoth program we are doing 151 city. And that too, if you add the panelists, it is more than 100 panelists, they are sharing their view in this podium. I don't know which program had got such a big panelist across India. Not only in India, now we have gone abroad also, in international also. The entire program, let me tell, almost it is getting attended by more than 25,000 doctors across India. And everywhere we have got a speaker, the eminent speaker, and we also have 10, 11 international speakers also. And hopefully sometime we will have arranged in this place as well for international forum. As I said that today's program is of panel discussion. So before that, I will request Dr. R.K. Mishra sir, he is our chief guest today. And before calling on the stage, I just wanted to introduce a bit, though it is quite troublesome for me that Dr. R.K. Mishra ji को हमको अगर जमशेदपुर में introduce करना पड़े, but it is my duty I have to do. So Dr. R.K. Mishra sir has done MD FICB from IMS VHU Varanasi. He is a consultant physician, diabetologist, and ex-president of CSI Jharkhand Diabetic Association also. And he has done many national and international publications, and he had also done research on insulin of Novartis and Sanofi. He is a national speaker in CSI and RSSDI, and of course we are proud, he had represented in many international conferences like Cyprus, Hong Kong, Singapore, Manila, and etc. So this is a little bit about Dr. R.K. Mishra, and now I state my request him to please come to the stage. I request Ramesh to escort Dr. Mishra to stage. And at the same time, sir, we wanted to listen a little bit from you, and you are always there in last 4 years, you are our chief guest, so we wanted to hear this time as well. Thank you very much.
Thank you, Mr. Singh, for the people in this town, because I am practicing in this city since 1986. It's quite a long year now in Jamshedpur, and I propose to spend my rest of life here only. So good evening, ladies and gentlemen. Present here, I am indeed honored to preside before such an illustrious audience and such a beautiful and mega conference like this IAMICON, which is on almost across India. Being in the medical profession myself, I feel we as a community need to address healthcare in a more holistic approach. This I have learned in my long 40 years of practice. As doctors, we might encounter around 30, 40, 50 patients a day, each walk through our door with a problem, the solution of which lies in our education and experience. Typically, they cover a symptom, they convey a symptom to us, which we diagnose and treat through investigations, examinations, and medications. These few moments of consultation is where I believe our service makes a difference. Healthcare as a term has two words. Basically, health is one, for which we are all intellectually equipped, but what lies more is care for well-being. Care for well-being is extremely important. Wellness emerges from diagnosing the physical, mental, and emotional health of a person. As WHO has said, today we are aware that the new generation of diseases are not stemmed out of viruses, plagues, or malnutrition, but due to unhealthy lifestyle, includes smoking, alcohol, obesity, and of course stress. I really feel pity, especially for the younger generation, people living in especially the metros and where they are working in various corporate sectors. I'll be surprised. Every day I see patients, young boys, 24, 26, 27, 28 years, suffering from severe acute stress disorder, especially working in IT industries in various metropolis and places like Bangalore, Pune, and all that. And their parents brought those young man to me, and they suffer from various acute stress disorders, and I really feel very bad that maybe a time will come that this young generation, more than 50% population may suffer from various mental disorders like depression, stress, and so forth. So this is really unfortunate, and that we should try to correct. And these diseases, they do not have any vaccines to inoculate society from these chronic lifestyle diseases. And diabetes is also, of course, one aspect of it. This because of unhealthy lifestyle, obesity, and all this fast foods. That's why India is fast becoming a diabetic capital of the world, and I really feel bad about it. So that's why pursuing wellness is the need of the hour. Wellness is a concept which has been in vogue in India. It's not a new thing. It was in India since ancient times. Traditional health practices such as yoga, Ayurveda, in fact the whole Ayurveda is based on this, have propounded the concept of physical as well as mental health. And with the progress of time, wellness has become a concept that has assumed a dynamic definition, including the individual's desire to be emotionally healthy. Today, Government of India has various wellness clinic all over India. I don't know, but there are a lot of controversies, and it is regarding the functioning and all that. I really don't know. So wellness has become a concept that has assumed a dynamic definition, including the individual's desire to be emotionally healthy. Chiefly influenced by changes in society and in the lifestyle of individuals, this change has also been accelerated by various extraneous factors such as higher disposable income and urbanization. As the income increases, as the urbanization increases, so as these diseases are increasing all over India very, very fast. Wellness as a term has never been more in vogue. That's why this term has become very popular now. With the rise of technology, we have various apps, especially in our mobile phones, that help people eat, exercise, and sleep better. The rapid innovations in healthcare, such as precision medicine. Again, the precision medicine, I think most of people might be aware what this precision medicine means. That means I was surprised in one talk that whatever medicine you prescribe, almost, the study was done abroad, 45% of medicines may not be effective. So it is extremely important to have a precision medicine for the right patient, which patient will be effective, which patient will not be effective, and various terms have been devised like pharmacogenetics, pharmacogenomics, and all those things. So precision medicine has come up a very big way these days, and a lot of people are talking regarding this. So, uh, so, so what I was telling, molecular diagnostics, precision medicine, molecular diagnostics, cancer profiling, cellular therapeutics, hormonal therapies, metabolic disease again is a big thing, is a big burden. Metabolic disease treatment shows the shift in the focus towards wellness. So it is no more only infective disorders.
So thanks a lot, sir, for such a wonderful insight on medicine and treatment as well. Now straight away we will start our today's medical session. And before that, I will request only one request. I have already said that I have attended. We are doing IAMICON in 150 cities across India, and I have attended around 10, 11. Let me tell, sir, such a fantastic gathering I haven't seen in that cities. So it shows the interest for medical in Jamshedpur is fantastic. I request, please do clap for yourself only. It's a wonderful presence, and I'm also proud that we in our city people take so much keen interest in the medical session. So now for our today our moderator is Dr. Vijay Kumar. I will request sir, please come up the stage. And once again, it is my customary duty to introduce him. Though you all know, बहुत tough हो जाता है कि वहीं के मेरे को introduction देना पड़ा. It's very tough. You all know him. But anyway, Dr. Saab has passed his MBBS in 1986 from MGM Medical College only, and he has done his DCH in 93 to 95 batch from Darbhanga Medical, and he has done his MD from RMCH. Dr. Saab has joined in earlier days, he has joined in Bihar government, and then he is a visiting specialist in Tata and Railway. He is practicing as a gastroenterologist here in Brahmanand Narayan Hirdale Hospital. And also he is associated with a few of more institutes here like Guru Nanak and Kamal Clinic, like that. So big round of applause for our moderator of today, Dr. Vijay Kumar. Now the panelists, let me start. A big round of applause for Dr. Biblendu Kumar. Sir, please come to the stage. And a little bit about Dr. Biblendu Kumar. He has done his MBBS from MGM Medical College, DNB in General Medicine in 2004, and DNB Cardiology in 2009. And sir is a very senior practicing doctor here. So big round of applause for Dr. Biblendu Kumar. Our second panelist is Dr. Satish Kumar Prasad, senior consultant and unit head in Tata TMH. He has done his MBBS in 1989, DCH in 1991, and MD in 1994. Please do come over here, sir. Please speak. Thodi sir tali ho jaye, because they are going to take the session forward. Our fourth panelist, Dr. Vijay Sinha. He has graduated from MGM only, and served GSBM Kanpur. And after 32 years of practicing in Tata Men Hospital as an orthopedic surgeon, he has done his MBBS and MS. And after that, his retirement, he is very much associated in many social work across this part. So please do come, sir, to the stage. A big round of applause to Dr. Vijay Sinha. We had one more panelist for the show, but gynecologist Dr. Renuka Chaudhary, but she had got a very serious patient in the evening. She was supposed to come at 7, but still she has come. She has told that she will make it if possible. So we'll wait for her if she will join. Now, sir, straightway, and the most young and the most dynamic, Dr. Kundan Kumar. Please give a big round of applause to Dr. Kundan Kumar. He has done his MD DNB Medicine in 2010, DM from ACPGI 2014, DNB Gastro 2014 and MRCP as well. He is a consultant and head the Department of Gastroenterology TMH since 2015. And let me tell sir, please give a big round of applause to him. He is a gold medalist in MD Medicine as well. We are honored to have our young and very dynamic panelist for gastro segment. And I have already said for the gynae segment, we will see if you can make it is yours. Thank you very much, sir. Thank you.
Good evening, dear doctors. Medical advances need to be at the leading edge of the discovery and the innovation and cannot be held back. Doctors have traditionally been adapted and have embraced positive developments. We are pleased to invite you to participate in this year's IAMICON in your city. Regarding the scientific component, there will be panel discussion on the topic learning from the expert, chronic diseases, insight, advances and the challenges. The panel comprises of experts from the field of the cardiology, diabetology, orthopedics, gastroenterology and the gynecology. The discussion will be focused mostly on the chronic disease like the coronary artery disease, hypertension, dyslipidemia, diabetes and its complication, osteoarthritis, osteoporosis, IBD, GERD, PCOD and the pregnancy related issues. The panel discussion and the open forum session incorporate inter-specialty discussion which will provide an opportunity to discuss and respond to a series of questions about the current and the evidence-based practice on the various chronic diseases. The duration of panel discussion will be 60 minutes which includes interaction with the audience. In the end, we will take up the question with the panelists. We shall be able to entertain only 2 questions per person from the audience and will note down the question to be asked from the panelists during the panel discussion. We will take up at the end. You are most welcome to participate and share your question, queries, update, experience with the expert panel and make this one kind of multi-specialty panel discussion a great success. Your enthusiasm and active contribution to this important panel discussion will be greatly appreciated. To begin with the questionnaire, my first question to the Department of the Cardiology. It has been seen many times that the pregnant patient have high blood pressure. So what special care to be taken in managing pregnancy-induced hypertension and what all are challenges to the cardiologist?
Just 1 second. I am the president of Jamshedpur, Dr. Umesh Khan, sir is here. I will request please do come to the stage and please honor us by presiding on the dais. Give a big round of applause to Dr. Umesh Khan, sir. Thank you very much, sir. We are honored you had come here. Please carry on, sir.
The question asked to me is, it has been seen many times that pregnant patients have high blood pressure. So what special care to be taken in managing pregnancy-induced hypertension and what are the challenges? The definition of hypertension does not change in pregnancy. It is the same. Any blood pressure more than 140/90 at whatever stage is around 8 to 9%. It can be, the hypertension can be there from the beginning before conception. The young lady can be hypertensive, or hypertension can develop after conception also. That we call pregnancy-induced hypertension. But definition for hypertension is same for both groups. What are the challenges, especially in pregnancy? As we know that pregnancy-induced hypertension or hypertension in pregnancy is associated with many fetal complications and also maternal complications. The maternal complications could be further rise of blood pressure, leading to development of albuminuria, accelerated hypertension, and if uncontrolled, can even manifest with neurological complications. Fetal complications can be because of low birth weight, prematurity, and even miscarriages. So, as per definition and management is concerned, those patients who are already having hypertension and they are on the drugs, whatever drugs they are taking, they can continue to take their drugs except for ACE inhibitors, ARB, and direct renin inhibitors. These drugs are absolutely contraindicated in pregnancy. These drugs has to be stopped before conception, ideally. But if it has been diagnosed after conception, then as early as possible it should be stopped. During pregnancy, the drugs which are preferred to be continued are, as we all know, labetalol, methyl dopa, and calcium channel blockers. Other groups of drugs are not well tested, but these three drugs are well known and have got very good safety profile, and they should be continued to manage hypertension in pregnancy. One more recommendation is that those who are having PIH or hypertension should also take aspirin from 12 weeks to 36 weeks to prevent further neurological complications, especially in baby and also in mother. Regarding accelerated phase of hypertension in pregnancy, the drug of choice is definitely IV labetalol, and if required, nifedipine can be added. If there is any episode of congestive heart failure, then drug of choice is nitroglycerin. Sodium nitroprusside should be avoided. Should be the last drug of choice. And earlier, hydrogen was also considered a drug of choice, but now it has been reported that it is not as safe as it was considered earlier. So, for managing hypertension, we have to continue keeping close monitoring towards the blood pressure, and also look for any complications if the blood pressure is not controlled. And if required, patients should be monitored in hospital if the blood pressure is more than 150 by 100. Thank you.
My next question to you again, sir. How common complications seen in pregnancy during the pregnancy? Sorry. Okay, thank you. Sorry. Again.
Thank you. The question is how common complications
Seen in pregnant
in
women.
pregnant women with valvular anomalies. How serious complications are valvular heart disease during pregnancy? As we know, valvular heart disease could be rheumatic or non-rheumatic. In Western population, rheumatic heart disease is not as prevalent. The incidence of non-rheumatic heart disease, especially bicuspid aortic valve, is more prevalent. In our population, valvular heart disease in pregnancy means it is rheumatic heart disease only. The rheumatic heart disease in pregnancy could be either a stenotic lesion like mitral stenosis or aortic stenosis, or a regurgitated lesion like mitral regurgitation or aortic regurgitation. The symptoms are more prevalent, more common in stenotic lesion, especially mitral stenosis, because as we know, pregnancy is associated with rise of blood volume more in the last few weeks of the first trimester, and it keeps on increasing till the 36 to 38 weeks. So, because of rise of volume, because of fall of peripheral resistance, there is more chances of the patient developing symptoms. In our country, many of the times, mitral stenosis first time diagnosed in pregnancy because of their shortness of breath. So, mitral stenosis is the most commonest and it is most troublesome. If required, patient should be treated before conception. If somebody is having mitral stenosis and valve area less than 1 centimeter square, it is ideal that patient should undergo valvotomy before conception. But if it is diagnosed in the second or during the continuation of pregnancy, valvotomy can be done at any moment of time by taking appropriate precaution of fetal shielding. Regarding future pregnancy, definitely future pregnancy should be avoided till mitral valve area less than 1 centimeter square, and it should be only planned after the valvotomy has been done. Regarding regurgitated lesion like mitral regurgitation or aortic regurgitation, these are better tolerated during pregnancy, but then also they also have serious consequences when the patient is having very large LV cavity or having LV dysfunction. They can also land in congestive heart failure. So it is always advised that the valvular heart disease should be taken seriously, and patients who are having valvular heart disease should be managed by pregnancy heart team in the hospital, especially in the hospital which has got multidisciplinary approach. And pregnancy heart team should comprise of a cardiologist, an anesthesiologist, and also a gynecologist. All these three doctors should be part of the team and they should take joint decisions regarding future management of the patient. Thank you.
Thank you. My next question to the guest. What are the common gastrointestinal complications observed in patients with the diabetes and what are the challenges? And my second question is, how different is the management of the diabetic gastroparesis compared to non-diabetic gastroparesis? Give your opinion in gastrointestinal reflux disease in diabetes patient.
Good evening. Diabetes, as all of us know, it's a systemic disease, and we all are well versed with the diabetic neuropathy, nephropathy and retinopathy. But GI tract is also not an exception. Diabetes affects each and every organ of the body, and so the GI tract and the liver. If we look at the gastrointestinal complications of diabetes, it's mainly dysmotility related because of the underlying neuropathy. These patients tend to have diabetic gastroparesis. They can have motion abnormalities of the small bowel tract, even colon. These patients often they present with bloating, nausea, vomiting. They may have diarrhea, they may have unexplained constipation, even fecal incontinence is known. Most commonly we often encounter these patients coming with a lot of bloating and nausea, vomiting. There are two aspects when we are dealing with patients of GI problems in diabetics. You have to see this can be due to two reasons. One, per se due to diabetes, and other is due to the use of drugs in diabetic patients. There are certain drugs like metformin, acarbose. These are known to cause a lot of GI side effects. They cause a lot of bloating, they can cause diarrhea, and many times you have to avoid these drugs to take care of those complications. And if we look at the diabetes per se, autonomic neuropathy is quite common. That leads to delayed gastric emptying. These are the patients, they are more prone to gastroesophageal reflux disorders also. Even OHA have been shown to increase the risk of gastroesophageal reflux. Why these patients tend to have gastroesophageal reflux? They have delayed clearance of esophageal volume as well as acid due to motility disturbances. They can have reduced salivary gland secretions due to underlying neuropathy. They have delayed gastric emptying that leads to reflux episodes. They have increased transient lower esophageal sphincter relaxation. These are the underlying mechanisms which predispose these patients to more episodes of gastroesophageal reflux. When we look at the management of these patients, the management is predominantly use of a PPI or a prokinetic to improve the gastric emptying of these patients. These patients often have to have a strict lifestyle modification. We often advise them to have small frequent meals. Don't take Bigger means don't take too much of water immediately after food. Take smaller means increase the frequency. Have a walk after each meal. And then again, you can support it with the drugs. There are a lot of prokinetics available now. In diabetics, especially the recent ones like etopride and levosulfuride, they help a lot in these patients. Now we have a lot of other newer molecules like acoshamide available that can be used in patients with diabetic gastroparesis, especially with symptoms of bloating. So these are the issues in managing diabetic patient. Another major factor is control of sugar. Like other complications of diabetes, if your sugar is not well controlled, these GI symptoms will worsen. Acute hyperglycemia has been known to delay gas emptying. So if you can control sugar better, then automatically many of your GI symptoms will also resolve. So the focus should be on strict glycemic controls, and then we use these PPIs and prokinetics in adjunct to improve the symptoms. And they need a careful monitoring for other complications of diabetes, and that has to be managed in conjunction with physicians, diabetologists, as well as gastroenterologists. Thank you.
Thank you. My second question to you again, how the cases of IBD, how the treatment differ in cases with active disease and those in remission?
IBD, inflammatory bowel disease, that is ulcerative colitis and Crohn's. This is a unique disease, and with pregnancy it's a bit challenge to tackle it. It's a pure GI specific illness. If you look at the outcome, how the disease affects pregnancy and how the pregnancy affects the disease. When we look at that, whether the course of IBD gets altered due to pregnancy, it's not. The severity of the IBD does not get altered with pregnancy, but IBD do affect pregnancy if the disease is not controlled. The only factor which predicts poor outcome of pregnancy is the higher disease activity in pregnancy. If the disease is more active, then the chances of low birth weight, stillbirth, small for gestational age, these are more common in patients with active IBD during pregnancy. Another issue with these patients of IBD is the fertility issue. If you look at the patients who are using one of the drug which is used in IBD is sulfasalazine. So this is the drug which is known to cause a lot of sperm abnormalities in male patients. So if any couple who is planning to go for a child, the male partner should stop sulfasalazine at least for 4 to 6 months. And again, the fertility of female by IBD as such is not affected, but it has been shown that those patients who undergo surgical treatment of IBD, ulcerative colitis, that is proctocolectomy with ileoanal pouch anastomosis, their fertility is lower as compared to the normal healthy young female patient. So these are the two issues of fertility in IBD. The drugs to be used in pregnancy during IBD, there are only 2 drugs which needs to be avoided. That is, one is methotrexate, the other is thalidomide. Thalidomide is usually not used nowadays. Another drug is azathioprine. Azathioprine is pregnancy category D drug, so it's better to avoid it. Rest of the drugs like 5-ASA, mesalamine, mesalamine is a pregnancy category B drug. Corticosteroids falls in category C drug, and cyclosporine again is a category C drugs. Depending on the severity of the IBD in pregnancy, as we use in other patients, we can use these drugs safely. They are not contraindicated in pregnancy, and these patients obviously need to be managed as a high-risk pregnancy. They need a close monitoring, and the fetal monitoring part is very important because they are more prone to have a small for gestational age, preterm birth, preterm labor and all. So these are the major issues while managing these patients. If the patient is, many patients they get first diagnosed during pregnancy. So standard protocol of management is similar as we manage in non-pregnant patients, and they need a close follow-up during pregnancy, and the treatment continues after C delivers. There is no, as such, it has not been shown due to disease. It has not been shown that fetus tend to have more fetal malformation. That is not seen with this disease. So I think it's a multimodality management in conjunction with gynecologists and gastroenterologists. These patients can be managed better.
Thank you, Dr. Kundan. Gynecologist and as well as for the diabetologist, as we don't have the gynecologist with us, so I request Dr. Satish to please focus on the answer of this question. What are the common metabolic complications observed in pregnant patient and what are the challenges? Does PCOS and the diabetes are two sides of one coin? What special care does such patient require?
Thank you. I'll be brief a bit because I have to cover other topics also apart from the topic given to the gynecologist. The common metabolic disorders which are faced during pregnancy are obesity, number one. We have fetal distress situations, IUGR, preeclampsia. There are injuries during delivery, and you must have heard the term gestational diabetes, which is so common now, between 24 to 26 weeks of pregnancy, a state of insulin resistance. So these are the common complications which are faced during pregnancy, and they have a very bad outcome leading to mortality and morbidity. And thus the physician or the gynecologist should screen the patients or the ladies who are planning to be, to conceive and become mother. There should be pre-conception counseling. There should be education regarding diabetes if they are a known diabetic, and all the let down protocols, antenatal, natal and postnatal, should be followed. As far as polycystic ovarian disease or syndrome, this is a distinct identity or a risk factor for diabetes. This is now emerging as a very common condition with androgenic manifestations in the form of hirsutism, clinically seen in young ladies. When you suspect about the PCOD, you ask for an ultrasound pelvis and this is diagnosed. If these patients of PCOD are kept on insulin, it has been found that once you stop insulin and switch over to the oral antidiabetics, they respond better. So metformin is the drug of choice which is given in this PCOD condition. But one thing one should keep in mind, that once these patients conceive, you have to stop the oral antidiabetics. They need not continue with it. Thank you.
Sir, in your opinion, should a patient will...
Let me add a few things. I'm sorry to interrupt. Let me add a few things regarding diabetes and pregnancy. In diabetes and pregnancy, there are two very important things. One hand, patient might be diabetic before and then she develops pregnancy. And the second thing is the patient develops diabetes during pregnancy, what we call gestational diabetes. I'll add nothing much. I'll add only thing is that once diabetes develops during pregnancy or pregnancy during diabetes, whatever it is, the criteria of hyperglycemia or blood sugar is very, very strict. Is very, very strict. You cannot have a leniency regarding blood sugar level or HbA1c level in any of the trimester. Otherwise, the chances of stillbirth and diabetes-related complications are quite high. So far as the metformin is concerned, during PCOS, and PCOS patient develops diabetes, now the recommendations are that you can continue with the metformin throughout pregnancy. There is no contraindication to it. If you want, you can continue if the sugar is not controlled. If the sugar is controlled, then patient can be off metformin. Ideally, everywhere, insulin is the number one choice for controlling blood sugar. And especially, though now the analogs are also recommended, newer insulin analog, what you call designer insulins are also recommended. But by and large, the human insulin continue to rule in pregnancy with diabetes, and majority of us would like to put the patient on human actropid or what you call human insulin only, any of the human insulin only for control of blood sugar. And the only thing is the criteria has to be extremely strict, very, very strict. HbA1c to the tune of around less than 5. Ideally, it should be less than 5. At the same time, patient should not develop hypoglycemia as well. Thank you.
Thank you, sir. Thank you, sir.
As far as the criteria are concerned, I agree with Dr. Mishra, and he raised a very important. I mean, this ADA has given a clear-cut guideline for maintaining these glucose levels. It should be in the first 10 weeks of pregnancy the target should be HbA1c less than 6%. But as the pregnancy advances to second trimester and third trimester, the target should be between 6 to 6.5. But if there is a chance of hypoglycemia or any history of such kind, then the target should be maintained less than 7%. If you convert it into the milligram percent values, the fasting blood sugar should be less than 95 milligram percent. The first hour PP glucose should be less than 140 and 2 hours PP should be less than 120. These are the guidelines by ADA 2018 for pregnancy and diabetes. And there are many issues which we might come across if the blood sugar is not controlled, especially in say first to 10 weeks. There are many anomalies. We call it colotruncal cardiac anomalies in the form of anencephaly, microcephaly, vertebral anomalies. And others, as we have all mentioned, like IOGR and all those things. So these complications are quite common if the blood sugar is not controlled or the treatment is not being given in the 1 to 10 weeks of pregnancy. And after that, other complications, as I said, gestational diabetes in 22, 24, 26 might occur. And treatment, as far as treatment is concerned, of course, insulin does not cross this placental barrier to that in such a manner that you can measure it. So very small amount of insulin crosses the placental barrier, so the fetus is not at harm. But if you start few oral antibiotics like metformin or glyburide, which are recommended and can be given, but with a potential hazard that these two drugs cross the placental barrier. Metformin level has been recorded up to 50% to the blood level in the placenta, and glyburide also up to 70%. And they have a potential hazard because metformin is safe to a great limit, but there can be immaturity, fetal immaturity. And if the recommendation is taken in consideration, the best is to start with insulin. If you ask with metformin or glyburide, which one is better? Metformin is better than glyburide. There are many studies which have shown that metformin scores over glyburide. And after this pregnancy is over, then you have to again assess the patient, because, as I said, the requirement of insulin suddenly drops to the pre-pregnancy level. So patient might not require that much doses, or even you may stop the insulin and switch over to oral therapies. Thank you.
Thank you, sir. Once again to you, is the management of diabetes is different when it is in pregnancy than non-pregnant patient?
Definitely, absolutely different. Whether a patient, as I said, the patient might be a known diabetic and has conceived, or the patient has developed diabetes later on in the course of pregnancy, and or the patient is pregnant but normal patient, because the entire physiology and pathology differs in these conditions. As I said, this counseling is very, very important if a diabetic patient is going to conceive, and she has to be educated regarding all the complications and events which might take place during the 9 months of course. This is very, very important. As far as diabetic lady, as I said, the complications in the initial 10 weeks, I mentioned already, the anomalies and what happens when the mother's blood is showing hyperglycemia. The fetus will have hyperinsulinemia, and this hyperinsulinemia will lead to all the complications expected in fetus, like macrosomia. Macrosomia can lead to difficult parturition. There can be injury to the fetus while the delivery takes place, to injury to the mother, and the instruments being brought in to take out the baby, leading to shoulder dystocia and all those things. It has also been observed that the diabetic patients who carry on with the pregnancy and they are having retinopathy also. Retinopathy. What happens if suddenly, after the pregnancy and with the consultation of diabetologist, the sugar is meticulously controlled. What happens? There is sudden worsening of the retinopathy. The retinopathy, which was grade 1 before conception, might turn out to be grade 3 or grade 4 later on after the blood sugar is meticulously controlled. Another thing which you have to keep in mind, if the patient is diabetic and also having nephropathy, which is a very common condition, then the chances of IUGR is very, very high. So you have to take care of the nephropathy part in a diabetic patient who has become pregnant. As far as the drugs which the patient was taking before becoming pregnant, you have to keep an account about those drugs. As Dr. Bimnendu said about hypertension, so is also correct for diabetes. The patient cannot continue with ACE inhibitor, ARB or statins. These drugs have to be stopped once the patient has conceived. So you have to, or there are many drugs which can further them. All the teratogenic drugs has to be stopped after the conception. And you have to keep in mind about the gestational diabetes, so you have to screen for that. And one very important thing which one should keep in mind, I think the gynecologist colleagues who are here will agree with me, that a diabetic patient cannot continue her pregnancy after 38 weeks. The labor should be induced after 38 weeks, so that the complications which is expected because of macrosomia is not come across. So you have to induce labor at 38 weeks of pregnancy in a diabetic setup. And after the child is born, the child should be, the baby should be given breastfeeding as early as possible to prevent this fear of neonatal hypoglycemia. So neonatal hypoglycemia is very, very common in diabetic patients. So early breastfeeding gives a very big advantage in such situations. You have to keep in mind about the lady who's given birth to the baby. The baby might become a diabetic later on, with the potential of becoming diabetic, and the mother also becomes normal, and then later on after 2 or 3 years, with the history of gestational diabetes, might again turn to be a frank type 2 diabetic. So these are the things I think one should keep in mind. I think there are many questions which might be coming to your mind. We'll discuss about that during question and answer session. Thank you.
Thank you. To orthopedician.
Hello.
If a patient is on intra-articular corticosteroid, should the dose of hypoglycemic drug be increased?
Yes, you are right. In the case of intra-articular injections, one has to take care of the diabetic status. If he is poorly controlled or not on proper medication, it has to be properly controlled, properly observed, and the dose of additional anti-diabetic drug should be given, or injectable insulin has to be recommended, because the chances of blood sugar going very high and there might be some complications also. So it should be properly monitored and additional drug has to be given, or injectable drug should be.
To Dr. Satish Gupta, you want to add something on it?
I think as far as iatrogenic hyperglycemia is concerned, or what you call steroid-induced hyperglycemia is concerned, I think the incidence is quite high. It's 10%. I mean, knowingly, unknowingly, I mean, we have to give steroid, I mean, in many conditions, and patient develops hyperglycemia. The worst part is that if the patient is a diabetic, undiagnosed diabetic, patient is an undiagnosed diabetic, has been instituted steroid, develops hyperglycemia, treated with anti-diabetic drugs, sugar comes down to normal, but as the patient was an undiagnosed diabetic, might continue with diabetes later on because of this institution of steroid, because of some reason. So this has to be kept in mind, that it may not be a temporary phenomenon that once you withdraw or wean off steroid, sugar will come down to the baseline. So it is quite possible if the patient has hidden or undiagnosed diabetic, might turn out to be a frank diabetes forever. Another thing is there are few studies, very few studies which have been done. I think most of the studies have been done in UK, in Lancashire and Manchester. There are 7 studies, and all those studies have reported that it is not necessary that after the institution of intra-articular steroid, there will be a sudden hyperglycemia. It may take 2 to 3 days or even weeks for hyperglycemia to be manifested. So, what is important? The patient has to monitor his blood sugar with what you call SMB, that is self-monitoring of blood glucose, with glucometer, and once the level crosses the recommended threshold, should report to the diabetologist or to the physician, who will recommend the treatment. And even the treatment part for this hyperglycemia is quite interesting, because once this hyperglycemia sets in or diagnosed, it may not even settle immediately after treatment. So it may take even months to settle down. And the highest value which has been reported after this intra-articular steroid is up to 500 mg/cent. So after one single intra-articular injection, the blood sugar might shoot up to around 500 mg/cent. So these are the few things about intra-articular steroids. Thank you.
Thank you. To the orthopedician again, what are the complications of intra-articular corticosteroid for the orthopedician as well as for the other specialties? And second one is, what is the maximum duration of NSAID can be prescribed, and if not NSAID, what other treatment option should be considered?
First, the answer on the first question is the side effects of the intra-articular steroid is the hyperglycemic state in a particularly diabetic patients increases, which has to be taken care very seriously. The second is subcutaneous atrophy of the skin, and the third one is hypopigmentation of the skin. And in female especially, there may be some menstrual disorders. So it has to be taken. This is the side effects of the intra-articular injections. And as far as the most common complication is the hyperglycemic state, and about which Dr. Satish Prasad has already explained the things. The second thing, what is the duration of NSAIDs? It should be continued as long as there is no side effect develops. Once side effects develop, one has to stop, and it has to be bare minimum, and again it should be supplemented by, if joints are involved, one should think of intra-articular steroids, because it will take care of his pain and inability for a long time, as well as physiotherapy is also one of the options in these type of cases where NSAIDs are not recommended or side effects have already taken place.
Thank you, sir. The last one is the what are the steps in the management of osteoporosis?
In osteoporosis especially, the basic treatment is vitamin D and calcium supplements. So, lot of preparations are available. Like vitamin D is available in daily doses, weekly, and even in the monthly doses, and calcium supplements are available. The biocompatible salts of calcium are available, which has a lesser side effect. And it depends about I think the monthly use of vitamin D3 is a better choice, along with calcium substance. Bisphonates are also there, and that can be used on a monthly basis. And nowadays, injectables are also available. Once, if it's convenient enough, you can take it on a yearly basis.
Thank you. So this one is the last one. Thank you to the all panelists and to the audience for their nice presence and attention. One word.
Just I want to involve this audience on a small discussion about duration of NSAIDs. But the question was there, how long the NSAIDs are safe. I will give you a small history about a patient, which happened just 2 days back. Patient came to our hospital with history of seizure, and he had some joint pain also on both shoulders. X-ray of the both shoulder was normal, and he was prescribed NSAIDs. Injectable Voveron. His creatinine on the day of admission was 1, and the third day his creatinine is 3. Is there any need to assess the chances of developing nephropathy before prescribing any NSAIDs to any of the patients? I think that this question is very valid, and we need to think over many times before prescribing any NSAIDs to any patient. What is your opinion, Dr. Sir?
I have managed many cases of arthritis, even the severe cases of arthritis I have managed for years. Once the patient presents, his suffering is so much that you have to think when to give, how much to give, what to give. As far as the NCI is concerned, of course, Dr. Bimandu has rightly said, before starting, you have to take care of his upper GI or lower GI. You have to take care of his renal status, his vascular status, hepatological status. Once you are assured that the patient doesn't have such type of complications, you can start with a minimum dose of NSAIDs, if possible for minimum duration. If the patient becomes asymptomatic, you can transfer the patient to simple paracetamol tablets or ultrasound, what you are using. But in many cases, patient doesn't respond, and you have to give, either you have to give or the other doctors will give. As far as GI part is concerned, you have to use some PPI inhibitor. Or as far as renal part is concerned, you have to take large amount of water and avoid use of other drugs that causes renal toxicity along with the NSAID, like gentamicin or any nephrotoxic drugs, other drugs. Just avoid those drugs. I have used even years, 5 years, 10 years, and it is the genetical part is the most important. The susceptibility of complications is mostly genetical, I am telling you. Even a 1 tablet of Voveron can give rise to large amount of bleeding, and even a years of Voveron doesn't give any problem. So you have to keep your eyes open, you have to keep the patient for.
Thank you. Anything more? Thank you all panelists and audience for their nice presence and attention. And I think there are many questions in your mind which to be taken during the dinner session. It will be the right one because there is a lot of delay already is there. So please. So, thank you.
Thank you.
Thank you very much, sir. Please give a big round of applause.